All right, guys, so I think that starts us here. My name is Blake Webb. I'm one of the veterinarians that works at Southeast Vet Neuro. I work in the Boynton Beach office. So welcome to our online CE. So today we're going to be talking about the neurological exam and how to achieve a localization, which is one of the big goals we have with that exam. A couple of housekeeping items. First thing is feel free to submit any questions you have throughout the presentation. We will be answering them at the end of the presentation. We'll have about 10-15 minutes saved for that. Other quick thing is you will get a CE certificate for today's participation. It's our CE. Know that it will be emailed to you 1 hour after this webinar ends. So just give it that full 1 hour and you should get that sent directly to you, but just know that it'll be a little bit of a delay the way the system works. All right. I'm just going to try to minimize myself here so that I can see more of what's going on. All right, here we go. Okay, so a quick little outline of everything that we're going to be going through today. So the big thing is obviously to go through the neurological examination and to go through the steps of how we do that and how we'll use those signs to help us achieve a localization. So where in the nervous system is this patient having a problem? We'll go through the 6 major categories here: sensorium or mentation, the cranial nerve exam, postural reactions or paw placements essentially, gait and posture, spinal reflexes, and also assessing a patient for pain. At the end, we're going to go through the functional and the anatomical regions of the brain, the spinal cord, and the peripheral nervous system. The peripheral nervous system is kind of its own thing, so we won't go through that in big detail, but we will go through classic signs of dysfunction that occur in each of those areas and kind of help pattern recognize some of our common syndromes. At the very end, we'll also have a chat about some of the special syndromes, some of the things that don't fit the classical rules that you can definitely see in private practice or in specialty, and kind of help better make assessment of those patients. All right. So the neurological exam, we have some big goals that we're trying to achieve when we do this exam. And the big one is the problem that this patient is exhibiting neurologic in origin, yes or no? So is the nervous system truly dysfunctional? Because there can be a lot of things that make a dog sick or depressed or not want to be, completely normal, but may not necessarily be neurologic. So we want to test that nervous system and make sure that it's functioning appropriately. And if it's not, we want to then know where can we pinpoint this problem. So if we're seeing true signs of dysfunction on the exam, we want to try to say, okay, is this problem arising from the brain itself? Is it arising from the spinal cord, or is it coming from the peripheral nervous system, an individual nerve, a neuromuscular junction problem, or potentially a true muscle issue? So the neurological exam, obviously we do it a lot as neurologists, but anyone is capable of doing this exam. You do not need an MRI or tons of expensive equipment to be able to do this. So the main things that you'll need is some reflex hammer or pleximeter. You'll also need a bright light. Hemostats work really well for testing pain and also the cutaneous trunci. And then you'll also just want these patients on a non-slip surface. So we have tons of yoga mats that we keep in our office, but any kind of non-slick surface that you can get them on, carpet, grass, turf, etc., can be really helpful because a lot of these guys will have some difficulty standing. So kind of jumping right into the exam. So the first thing that we want to assess is mentation. So is this patient alert? Are they responsive? Do they have appropriate behavioral cues? So this is overall assessed pretty quickly by just putting the patient down and letting them walk around the room. Are they able to navigate if there's chairs, if there's people? Are they looking for the door, looking for a window, typically trying to look for a way to escape? The levels that you'll want to be able to say in your neuro exam are what is the alertness of the patient? So are they quiet alert responsive, or are they bright alert responsive? We'll have some examples here in the next slide. The next one is the patient obtunded? And a lot of times, a lot of people write this as dull. So the dog is able to look around, can see things, but it's just not, alert, not like excited about anything, kind of looking a little lethargic is the easiest way to describe it. And you can describe that as mild, moderate, or severe, depending on their alertness. The next level is a stuporous patient. So when we say a patient is stuporous, generally these patients are laying on their side, they're not overall alert, they're not looking at you coming in and out of the room, and these patients generally only will respond to noxious stimulus. So this is when you'll take those hemostats and you'll pinch a toe or some skin, and you want to see them kind of wake up and look around, and if you stop that painful stimulus, they'll normally go back down to kind of being in recumbency. So if you get that kind of reaction, that would be a stuporous patient, and signs that we've had some more severe mentation changes. The last one we have is the most severe, so a patient that is comatose. So again, these are not patients that are wagging their tails and walking around or looking a little bit depressed. These are patients that are going to be recumbent, minimally responsive to what's going on, and these patients will not respond when you take those hemostats, you pinch a toe, tail, skin, they're not waking up and giving you a strong reaction. So those are patients that we would call comatose, and those are patients that are in a severe kind of altered mental status. So we would want to make sure that we refer these patients and get them some support. When we're doing the mentation check and we're trying to place where in the problem we have, or where in the nervous system we have this problem, we're going to consider forebrain, so the front wrinkly part of the brain, or the brain stem, depending on how severe the patient is. So generally, if you have a patient that's dull, not really wanting to respond very well, you'll think more of a forebrain problem. But if you have those patients that are in the severe states, so stuporous or comatose, you more worry about the brain stem. So where that ascending reticular activating system, or ARAS system, lives, travels through the brain stem. And so a problem there, tumor, inflammation, trauma, would cause more of those severe mentation changes. So here's some quick examples of what we would see in an exam room. So we have a nice happy golden here, we definitely a BAR. You have this little Chihuahua friend here. He's alert, you can see that his eyes are open. He's probably looking at people coming in and out of the room, but he's just not super excited. So we would call this patient quiet, alert, responsive. We have a little greyhound friend here that is what we would go more into kind of obtunded. So this patient's kind of walking around, but kind of has its head low, seems a little bit dull, lethargic, not being, alert and responsive. So this is a good example of what we'd call an obtunded patient. And then finally, we have a little puppy here that's in a food coma. So these would be the more severe guys, laterally recumbent, not responsive, not lifting their head, not looking at you coming in and out of the room. All right, so the next step in our neurological exam is we want to test the cranial nerve. So dogs have 12 cranial nerves that come from the brain and innervate sensation to the face, muscles, PLRs, all that kind of stuff. So we'll go through these in a few quick steps. I don't have long videos of doing this neuro exam. There's tons of them on YouTube, so I'd encourage you to watch and see how they perform this. But in the interest of time, we'll kind of go through it really quickly. So the first one we have is the cranial nerve 1, or the olfactory nerve, often forgotten. So if we have a patient that does not have a sense of smell, we call that anosmia. It's pretty rare to get that as a presenting complaint, but sometimes you'll have owners that say, hey, he can't find his food or his treats. And so that would be cranial nerve 1. Generally, when we're going to test this, we want to hide food or hide treats in our hands or underneath bowls, see if they can sniff that out. What we don't want to use is anything like a caustic chemical. So they used to put alcohol, on cotton balls and put it near their nose. That is not going to work as well, because the chemicals can actually stimulate the trigeminal nerve and actually irritate the nasal mucosa. So you're not truly testing smell. We don't usually test this that often, but occasionally, if you have a client that brings that to you, that's how you can test it. The next one is an important one. We have cranial nerve 2. So this is our optic nerve that carries our vision. So generally, we're going to test this by performing a menace response, remembering that that is a response, not an inherent reflex. So young puppies don't generally have this until they get a little bit older, and sometimes cats won't do it even at any age. And also testing PLRs and tracking of cotton balls if you're throwing them in the room. So there's potentially multiple areas of dysfunction if you have a patient that is not visual. So the big things you want to do is test your menace. So you'll cover one eye and bring your hand menacingly towards the other. They should be able to blink that eye completely. So the input is cranial nerve 2. They see you coming, and the output is cranial nerve 7, bringing down those muscles around the eye. Next, you'll want to test your PLR, so taking your bright light and bringing that over to the pupil. You want to see a full constriction in the eye that you're testing. Then you want to see a consensual constriction in the eye that you're not shining the light on. And you want to make sure that both of those are present in both of those eyes. We have to remember that vision is a pathway that crosses over. So a patient that has a right-sided brain problem could have an absent menace on the left side. And so we have that represented here. Testing, we'll say this is the left eye. This crosses over at the optic chiasm, and we'll go over to the right side of the brain for interpretation. So the next ones we'll do is cranial nerves 3, 4, and 6. We generally try to clump these guys together. So cranial nerve 3 is your oculomotor nerve. It helps with eye position and movement, along with 4, the trochlear nerve, and 6, your abducens. So generally when we're doing this, we're looking for, does the animal have any types of strabismus? So one eye being deviated laterally, ventrally, dorsally compared to the rest. And also we'll want to check their physiologic nystagmus, so taking their head to one side, bringing it to the other, and you should see the rapid movements of the eye following the horizon, and making sure those eyes do that in a synchronous order. All of these nerves innervate some of the ocular muscles around the eye. So the way that we kind of remember this is the superior oblique is innervated by 4, the trochlear nerve. The lateral rectus is innervated by 6, the abducens, and then all others, so all the other extraocular muscles are innervated by 3. So we have some examples here of what problems with the oculomotor nerve or cranial nerve 3 would be. You'd get your lateral strabismus. Your trochlear nerve that innervates these dorsal obliques or your superior obliques, if that is affected, you'll actually get kind of a lateral deviation of the dorsal part of the eyes, much more easy to see in cats that have our slanted eyes than in dogs that have more rounded pupils. And then finally, if we have a problem with 6, we're going to get more of a medial deviation of the eye because we're losing that lateral rectus muscle to pull it away. Finally, we have, next we have cranial nerve 5, so the trigeminal nerve. Trigeminal nerve has many purposes. There's 3 big branches that we're generally testing. So the ophthalmic branch, your mandibular branch, and your maxillary branch. So your ophthalmic will do sensory from the eyelids and the actual cornea itself. So when you do a corneal reflex and you touch a Q-tip to the eye, you should see the globe retract. The sensation part of that is the ophthalmic branch of your trigeminal nerve. And then you should retract your retractor bulbi from cranial nerve 6. The mandibular is motor and sensory to the muscles of mastication, so the chewing muscles will be your mandibular. And then the maxillary is the sensory to the superior eyelid and also your nasal mucosa. So we'll touch inside the nares there and see if the dog pulls back, pulls away, and you should see basically an irritation and know that that sensory component is working well. There is motor components of cranial nerve 5, and those are mainly your mandibular branches. So we also always want to check these patients for symmetry. So is the temporalis and the masseter muscle looking the same on both sides? Because if you have a dysfunction of that mandibular branch, you can see some atrophy or some loss of that muscle on one side or potentially both sides if both of the nerves are affected. So we have some examples of this. So we have a little beagle here on the left. You can see that he has marked loss of that temporalis and his masseter muscle down here. The zygomatic arch over his eye becomes very, very prominent compared to the left side of his face. Here we have a special case of a dog that has trigeminal neuritis. So both of his trigeminal nerves are affected, and you'll get a dropped jaw, so that that nerve isn't able to innervate those chewing muscles. They can't keep that jaw closed, so that jaw will stay dropped. You can kind of hit the bottom of their jaw and they can't close that. These guys will often froth and kind of foam at the mouth because they can't really keep the saliva in. So know that that's also a classic presentation for a cranial nerve 5 or trigeminal problem. Next, we have the facial nerve, so cranial nerve 7. So we kind of talked about, we can test this by doing the menace. So the output of that menace response is closing those eye muscles. So all of those come from 7. Then also we want to watch for facial symmetry. So we've all seen some patients that have facial paralysis or idiopathic facial paralysis. So you'll see the drooping of kind of those postural muscles of the face. So we have this little boxer here, and you can see his droopiness on that left side. The facial nerve is also providing some sensory information to the face, so tickling the pinna of the ear will also test that. There is also some innervation to taste to the tongue, the rostral 2/3, and also the facial nerve does support some of the lacrimal glands and salivary glands. So testing tear production in dogs that have that facial paralysis is important, because sometimes they're not able to produce a normal tear film to protect their eyes. So we want to make sure that they don't develop any ulcers or anything like that. And sometimes you'll see discharge in these patients that have the facial paralysis. All right, next we have cranial nerve 8. So this is your vestibulocochlear nerve. So it's called vestibulocochlear because there's 2 roots. You have the vestibular root that will give the brain input on the position of the head in space. So, you know, if you're balanced with the horizon, and there's also the cochlear root. So that's actually going to transmit information that the brain then perceives as sound. So when we're testing this nerve or looking for signs of dysfunction, we want to see what is the head and body position. So are they tilting their head? Do they have good physiologic nystagmus, so bringing their head left to right and watching their eyes come through? Do they have a pathologic nystagmus? So if they're sitting there still, are their eyes, you know, kind of going really quickly? And we'll talk about some of the types of nystagmus we can see. And then also testing for hearing would be more of doing a Bayer exam. These roots do run together to feed information into the medulla, so the very back part of the brain and the brainstem. And then when we do have these patients that have some vestibular signs, head tilts, or nystagmus, we want to try to distinguish those into 2 big categories. Is it peripheral, meaning the inner ear structures are being involved, or is it central, meaning the actual brain and the special nuclei that maintain balance, are they being affected? And we'll go through some examples of how to pick out those on an exam in just a minute. So this is our slide trying to better assess for vestibular disease patients, patients that are off balance. Are they central, meaning their brain is being affected, or are they peripheral and they maybe have an inner ear issue? So some things that would help you lean toward central would be any patient that has an abnormal mentation. You're going to think more brain involvement. These guys can have a head tilt and a wide base stance. Notice that that can also be seen in a peripheral vestibular patient. For the gait, you'll see some tetraphoresis, so a weakness in the limbs can be seen, and that is more of a concerning for central involvement, but circling and ataxia we can see in both central and peripheral. For central patients, you want to check the paw placement. So I was always taught, you know, with vestibular disease, the legs don't lie. So if you have paw placements on one side of the body and a head tilt on that same side, that's going to be the side that the problem is on. And we'll talk about checking paw placements down the line in the neuro exam. Any other cranial nerves being involved, so 5, 6, 7, 8, all the way down through 12. If you're seeing multiple cranial nerves involved and head tilt and balance dysfunction, that's going to be concerning that there's something going on in the brain, taking out multiple cranial nerves. There are syndromes where you can get facial paralysis and vestibular diseases that are peripheral. Next, looking at nystagmus, so any kind of rapid eye movements, horizontal, vertical, or even rotary eye movements are possible. Vertical movements tend to be more specific for central, but they're not always a slam dunk. And then finally, looking for signs of Horner's, so any kind of drooping of the face, inophthalmos or retraction of an eye, and a myotic eye, prolapsed third eyelid. We'll show a picture of Horner's later, but if you see that and a head tilt, it's pretty indicative of peripheral disease, and we worry about ear infections and things like that for those patients. We talked a little bit about nystagmuses here. I'll kind of show you some examples. So again, they can be vertical up and down. They can be horizontal, meaning going left or right. And we want to see what is the fast phase if they are horizontal, and then looking for rotary and some others. So this patient here has some both vertical and rotary and all kinds of nystagmus. This was a trauma to the brain. So these are the kinds of rapid eye movements that we want to check for. I'll play that one more time for you guys. All right, so next, we talked about vestibular disease, and we talked about it being one-sided, head tilts one way or the other. Sometimes we can get bilateral vestibular disease, so really common in kitty cats to get double ear infections from bacterial infections. So in these patients, they'll seem very drunk, very wobbly. You see this cat has really wide head excursions going both left and right, and this is pretty classic for a bilateral vestibular patient. You see this poor little kitty going back and forth with his head. So he's not one-sided, he's kind of both-sided in this example. All right. So rounding out our cranial nerves real quick, we have 9, 10, 11, and 12. So cranial nerve 9 is your glossopharyngeal nerve. So it has both sensory and motor components to the pharynx, some glands, and also for taste. Generally, we're going to test this by doing a gag reflex. So you can do that internally, sticking your fingers down the throat, making sure that you get a good swallow. For any patient that is aggressive, or for any patient that you don't know a rabies status, an internal gag is not recommended. You can generate one externally by putting firm pressure on the larynx and getting that patient to swallow. 10 is your vagus nerve, has tons of different purposes, and is named in Latin because it's wandering and rambling, has a really long pathway, but mainly know that there's sensory and motor input from this nerve to the palate, the pharynx and the larynx, the trachea, esophagus, also to some of the thoracic and abdominal organs. Again, we're going to test this by gag reflex. Any kind of voice changes or dysphonia, or signs of regurgitation that the esophagus is not working appropriately to move food down to the stomach. Next, we have the accessory nerve, cranial nerve 11. So you would look for any kind of signs of muscle atrophy to some of the muscles of the neck. Generally, it's really, really rare to see this nerve be affected on its own. Finally, we have cranial nerve 12, so your hypoglossal nerve. So this is the nerve that provides motor innervation to your tongue. So you do want to open these patients' mouth, look at their tongue, watch them eat, watch them lick their nose, make sure that there's not one side that seems to be atrophied or shrunken, make sure that they're able to eat and drink and do those kinds of normal activities. Asking the owners if they're able to eat well at home can also be really helpful. So this is a good example of a patient that has atrophy of the left side of the tongue. So cranial nerve 12 on that left side is not working for this patient. All right. So moving on, we're in our postural reaction. So our paw placements is generally what we're going to test. Know that we can test this in a couple of different ways. So we can do some standing paw placements, and I've got some pictures of how to test that in the clinic. We could also take patients up and kind of hop them, so move them on one leg and see if they're able to pick that leg up and move it as you're kind of tilting them off balance. We can do hemi walking, so taking the left front and left back leg, moving that patient over and watching them hop on the right side of their body. We can also do wheelbarrowing, so picking patients up by their back and making them walk along their fronts. And then you can also do extensor postural thrust, so picking a patient up and setting them kind of down right on their rear end, watching those back legs kick, and they should be able to bring those legs back underneath them. Obviously, when we get into large breed dogs, some of these things become a little bit of a physical impossibility, but for small breed dogs, they're generally pretty easy. So when we're testing, proprioception, paw placements, conscious proprioception, CPs is kind of often how it's taught. We want to know, does this patient know where their limbs are in space? Are they aware of where their limbs are in space? It's important to remember that the lesion can lie along multiple different areas. So in this nice little chart here, we'll say that we're testing proprioception here. So we're going to knuckle that back leg over on the back right. If that patient is able to pick it up, replace it normally, we know that the pathway through the nerves of the leg are working, the pathway through the spinal cord is working. This pathway does decussate or cross over, and it will go to the opposite side of the brain. So it'll go to the left forebrain to be interpreted. So patients with the left-sided brain problem, again, can have absent paw placements on the right side of their body. For vestibular patients, patients with head tilts and signs of balance dysfunction, remember that the legs don't lie. So if I'm tilting my head to the right, I have paw placement deficits on my right side, that pathway is being affected most likely in the brainstem before it's crossing over. So always watch your paw placements for those vestibular disease patients. So here are some examples. So first, large breed dogs, how do we test them? Obviously, it can be harder when they're heavier. So if you're young and have a good back, this is a nice way to do it on the left. So reaching over the patient, putting your arm underneath their chest to support their weight, and using your other arm to bring their foot upside down and making sure they pick it up and replace it appropriately. You want to make sure you're keeping these patients nice and steady and that they're not wobbling or trying to fall, because if you move them, their balance system will kick in and they'll try to catch their balance, and you're not truly testing just their paw placements and proprioception. This is also a really nice technique on the left for any dog that kind of has behavioral issues or aggression issues. If you're worried about them biting you, having your arm in that position keeps their head away from you and kind of protects you. For dogs that are a little bit sweeter, this old lab is very sweet. You can kind of take like a knee, like you're playing baseball, and use that to support the dog underneath their chest, and use your free hand to flip that paw over and make sure that they can replace it. For larger dogs, for checking the back legs, again, I kind of like to be down on one knee, put my arm and rest my elbow actually on my knee to help support the weight so that I'm not physically lifting an animal up, and then using your free hand again to check that paw placement in the back legs. You can do this for small breed dogs as well. But what I like for small breed dogs is I will actually place my hand completely underneath them between both of their legs, supporting their pelvis and their chest, and then flipping their paw over and making sure they can replace it. You can see this little Yorkie here has an absent paw placement on the left, and it's easy to get these little guys up on a table. All right, so moving on to the next big category, we have gait and posture. So when we are trying to describe a patient's gait, which is really important for any dog with a spinal issue, we want to answer a couple of questions. So again, is this patient able to walk or not? So ambulatory is the term we normally use. So can they get up with their own four legs and make it across the room, yes or no? If the patient is able to do it or not able to do it, we then want to know, is it abnormal, yes or no? So for patients that are able to walk, is there one of the four big categories of problems? So lack of motor movement or motor function movement of the legs. So if they're able to move but they're weak, we're going to use the term paresis or weakness. If this patient is unable to walk and is not moving those legs, we want to use the term plegia or plegic. We can add some modifiers to the front parts of those. So any dog that's dragging the back legs but able to move them, we'll call those patients paraparetic. So both of those back legs are weak. But for dogs that are unable to walk but they can move all four legs, we're going to call them tetraparetic. All four are weak. Obviously, if they're not able to move the legs, you'll say paraplegic, tetraplegic. Another big category is if they are able to walk and go across the room, is there an ataxia or an incoordination? There's three big types of ataxia that we want to be able to describe, and we'll show some examples of them. But one is a proprioceptive ataxia. So generally arising from a spinal cord issue. If you've ever seen a dachshund or a Frenchie, they're crossing midline, they look a little sloppy in the way they're walking. Very classic for a proprioceptive ataxia. We want to look for a vestibular ataxia. So this is kind of the drunken falling to one side. These patients generally have a head tilt or a nystagmus that'll help you kind of better lean into that vestibular ataxia. Finally, we have a cerebellar ataxia. So if there's been a stroke to the cerebellum, tumor, inflammation, etc., you're going to see these patients become wildly over-exaggerated and what we call hypermetric. So they have this very uncoordinated, over-exaggerated movement in their limbs. And we have some good videos of that at the end. The last two things we're going to look for in the gait is there a lameness? So is one leg lame or multiple legs lame? Because it's sometimes hard to suss out some orthopedic versus neurological issues. So we want to pay attention to that. And finally, I look for exercise intolerance or an inducible weakness. So sometimes patients start walking and they look great, and then we were walking them more, or making them run, and then you'll slowly see them sink down, slowly become weaker. And those are things that should cue you into more neuromuscular diseases like myasthenics and not true spinal cord or nerve issues. All right. So moving on to the last couple of sections here, we want to test spinal reflexes for these patients. So we do have both flexor and myotactic reflexes that we can check in patients. It's important to remember when we're doing reflexes, we're testing the nerves that are going up to the spinal cord, and then there's a reflex arc. So these reflexes aren't going to the brain or elsewhere, they're just going up to the spinal cord, and the signal is coming back down to the limb to do the reflex. So the big sections that we're testing, C6 to T2 is your front limbs. So you'll have biceps and triceps reflexes. These are generally not 100% reliable. They can be absent in normal dogs, but know that you can check those. The one that is truly sensitive in the front legs is a thoracic limb withdrawal. So we're going to pinch those patients between their toes and their little toe web, and we should see a full flexion of the carpus, elbow, and shoulder to get away from that stimulus, and it should be very quick and very strong. If we have a spinal reflex that we think is abnormal, we want to say, is it decreased? So they're not able to do it as well. Is it over-exaggerated or increased, which is really common for patellar, or is it truly absent? So sometimes you'll pinch really, really hard or even use your hemostats and that patient can't do a withdrawal. And so you want to say that there's an absent reflex there. The spinal reflex that we like to use for T3, L3s is the cutaneous trunci. So when we do that, we'll have patients, we'll pinch them right over the wings of the ilium, and you should see that skin twitch, kind of like a fly twitch that horses do. You want to see that skin twitch all the way down. If we don't get one at the wings of the ilium, we want to move up to find where do we get one, because where you finally get one will be the cutoff. There's generally a problem about two nerve segments cranial to where that cutaneous trunci will cut off. And so that's the way we can functionally test that T3, L3 or mid to lower back region. And finally, we have our L4 to S2. So these are the back legs. So you do have a gastroc reflex back there, again, can be absent in normal patients. We have the patellar reflex that we're very familiar with. So using our flexor hammer to, or reflex hammer to hit the patellar should see an advancement of our tibia. And then finally, you also have your pelvic limb withdrawal. So again, pinching between the web of the toes, watching the hip, the stifle, and the hock all flex together. And then you can also do perineal reflexes on either side, kind of checking for anal tone at the same time. You should see kind of the external sphincter kind of constrict down, and functionally you're testing your S1 to S3 segments there. All right, and we'll have some charts and kind of go over that in a visual reference here later. So lastly, we want to check all neurological patients for pain, because this can help distinguish differentials for these patients. So first things I like to do is palpate along the spinal column for pain or discomfort. Obviously, you want to be careful to not get bitten when you're doing these things, but you want to know if a patient is painful. So in any patient that may have orthopedic issues, making sure you're checking muscles and hips. But generally what I'll do is I'll put my fingers on either side of the spinous process, push all the way down the thoracic and lumbar spine. I will do a tail jack, so taking the base of the tail, going up and down, making sure that lumbosacral region is comfortable. In the neck, they have a lot of muscles that sit on the top of their spine, so pushing down on the neck generally isn't very helpful. But what you can find is the wings of their atlas, or their very first cervical vertebrae, and come down the side. And generally that can be way more helpful to trying to elicit if a patient is painful. Finally, any dog with neck pain, we want to know, do they have good range of motion? So going up and down, and sometimes they'll give some responses or have muscle fasciculations to show that that neck is uncomfortable. So very last thing, going back to our gait assessment. So for any dog that we assess is plegic, they are not moving a limb at all, we do want to assess, do they have pain perception in the limb? Do they have nociception? So you want to take your hemostats and actually pinch over the toe of that affected limb and see if this patient gives you a reaction. They should turn, they should growl, they should bark or yelp or give you something to let them know that they feel that. And it's important to do this because it is critical for prognosis. Losing the ability to feel in a limb kind of represents the greatest neurological damage that you can have, so that it can drastically change prognosis for a lot of patients. Please note that any patient that's able to walk or any patient that's able to move its legs, you don't generally need to test pain perception. So if you say a patient's ambulatory, paraparetic, you don't have to say they have pain. That's kind of implied by the fact that they still have that motor function. There's some very rare exceptions to that, but generally it's not something that you'll encounter normally. Okay, so we've talked about the neuro exam and all these individual tests that can kind of bog you down. So now it's kind of time to talk about, what does this mean anatomically? What are we truly testing? So, and the goals is obviously to try to localize where in the nervous system is the problem. So the things that we can pinpoint is the brain. The brain does have some specific parts. So we have the prosencephalon, kind of the forebrain, that makes up both the thalamus, hypothalamus, and kind of that wrinkly outer part, that forebrain that we talked about. And then we have the brain stem that's kind of the brain that's exiting, going back towards the end of the skull before the spinal cord. So you have your mesencephalon, which is your midbrain, your metencephalon that has both your pons and your cerebellum is included in that. And then you have your myelencephalon, otherwise known as the medulla. And the reason why we kind of want to know those things is the individual cranial nerves will come from specific areas of the brain. So from your forebrain, you'll have cranial nerve 1 and 2, so sense of vision and sense of smell. And then pretty much all of your other cranial nerves are going to come from your brainstem. So 3 and 4 from your mesencephalon, 5 is the only one that comes from your metencephalon, and then the rest, 6 through 12, are going to come from your myelencephalon. So some of the classical signs that we'll see for patients that have specific areas of the brain that are being affected. So forebrain, we talked about those postural reaction deficits, so those paw placement deficits going to be on the opposite side from the lesion. So left brain problem would have right-sided paw placement deficits. We can have blindness with the forebrain with normal PLR, so checking that menace, we're not getting one, but that optic nerve is working because we're doing those PLRs and they're working normally. That can be a brain problem. The brain's not processing that visual input. Any patient with seizures, that's a forebrain problem. That's where seizure activity comes from. Behavior changes, minor changes in mentation, so those dull or obtunded patients will worry about the forebrain. Circling behavior, head turns, not necessarily tilts, but turns, and then those cranial nerves 1 through 2. We kind of talked about the cerebellum a little bit, but over-exaggerated, very spastic, very uncoordinated, types of movements we will see. There's some special postures called decerebellate rigidity that we'll show a picture of at the end. And it is possible to have a menace deficit for patients with a cerebellar lesion. Finally, we'll have our sections of our brainstem. So the first one will be our mesencephalon. There's a specific posture that they can take with severe brainstem lesions. Again, we'll show pictures of that at the end. We would see weakness and incoordination in these patients because those motor pathways run through the brainstem. Major changes in mentation, obtundation to coma, in any deficit in cranial nerve 3 through 4. You'll think of that mesencephalon or the midbrain. The metencephalon and the myelencephalon will be fairly similar. Weakness, ataxia. This is where these vestibular signs will come from. So the myelencephalon, head tilts, nystagmus. You'll worry about that caudal part of the brainstem. And then cranial nerves 5 through 12 will be that pons and the medulla. So showing some videos of what some of these things will look like. So really quickly, this is a dog that suffered a really bad stroke to the right forebrain. So when I was showing this dog food to the left side of its body, it was unable to perceive that food was there. It wasn't until I brought it to the other side where the other side of the brain is perceiving that information that this dog was able to perceive that there's food there. So we call this hemi-neglect. So they're not able to perceive information on one side of their body. It's a very strong forebrain indication. Next, this is a wonderful example of a cerebellar dog. So this dog, I believe, had a brain tumor that was causing compression to the cerebellum. So you can see that this dog acts drunk. He's very uncoordinated, but look how incredibly over-exaggerated he is. He's like swimming with his front legs because he's very off balance, and he's lost the ability to kind of fine-tune those motor skills that all come from the cerebellum. Show that one more time. All right, one last classic cerebellum example. So again, we will see things like we don't have good coordination, good fine motor skills. So we have this little guy who you can see really constant head movements here. So his head is wobbling back and forth. So this is kind of commonly called the white shaker syndrome or idiopathic cerebellitis. So this is very common in inflammation getting into the brainstem. This guy didn't read the book, and he's a black and tan, but still kind of that classic presentation. All right, so getting to run out of time here a little bit, so we'll move things here a little quickly. I want to show you guys the spinal cord segments. So again, when we are going through to do spinal reflexes, if we have front limb reflexes that are abnormal, C6 to T2 is going to be the region that we're worried about being abnormal. That cutaneous trunci is the T3, L3 region. Then L4, S3 is the pelvic limb reflexes. If we have a C1, C5 lesion, generally our reflexes will be good, but we're going to see weakness and incoordination. And I'm going to show you some good examples of that. We'll move kind of quickly here so I have time for questions. So this is a classic C1, C5 myelopathy. So the upper part of the neck. This dog was a wobbler. He's post-surgery to remove the stenosis of his spinal canal. So you can see this guy has a good proprioceptive ataxia. He's crossing over. He is weak, and it's taking all of us to support him. Know that we can see neck pain and also potentially Horner signs with dogs that have C1, C5. Next, we have C6 to T2. So these patients can have a very classic 2-engine gait. So notice this tiny patient here is very quick with his front legs, but his back legs are very slow and kind of floaty. So this is called a 2-engine gait, very classic for dogs that have C6 to T2. we'll expect all 4 legs to be weak. You can get weakness on one side of the body or the other. You would expect his paw placements to be absent in all 4. You would expect to have reduction of reflexes in those front legs, but normal, in the back. T3 L3s are the classics, so any Frenchie, any Dachshund that you guys have seen in practice. So that mid to lower back, front legs should be normal. They can move them, they got good reflexes. We'll see problems in the back legs, weakness to paralysis, and then you can see some over-exaggerated reflexes in the back legs to normal. Also, you're going to want to watch the cutaneous trunci in these T3 L3 patients and see where it cuts off. This little guy is post-op from a disc herniation. You can see that he is pretty weak in those back legs. He did have some motor function, but wasn't moving them very well. But this little one made a full recovery, so he's doing good. Finally, a good little video of what an L4-S3 myelopathy looks like. So this dog is truly plegic, not able to move the back legs at all. So again, you'll expect your front legs to be normal in these patients, normal reflexes, normal paw placements, but you're not going to get good patellars or withdrawals in the back legs, which is the case for this patient. This patient also had pretty poor anal tone, which can happen if it extends backwards to the S3 regions. All right, so we're just going to breeze through the peripheral nervous system as kind of its own beast, but know that when you have neuropathies in patients, so true nerve dysfunction, you'll expect to see absent paw placement and decrease to absent reflexes and poor tone. If you have neuromuscular junction type problems, you should have normal reflexes like in your myasthenics, and even in myopathies, you should have normal reflexes. It's kind of more the tone and exercise-induced weakness that you're going to see to distinguish the nerves from neuromuscular junction or muscles. This is a quick example of a dog that was actually what I believe to be a polyradicular neuritis or a Kuhnhelm paralysis. So you can see that this dog is really weak. So you could think that potentially this is a neck dog, it's knuckling, but what's going to help you is the reflexes. So this dog does not have any biceps or triceps reflexes, has no patellar reflexes, and is really reduced in the withdrawal. So to have all of those reflexes gone, that's a nerve problem. You see how he can definitely feel it, trying to get away from me, but just can't pull that leg back. So real quick, patellar reflexes here. So we should be seeing a really good kick and a forward advancement of the tibia, and there's just nothing happening here. Tail works though. It's a very sweet dog. Also made a full recovery, just needed some time. So again, you can see that they can feel this and they're trying, but can't quite flex all the way. It was better in the back legs than the front, but just really weak. Okay, so I'll breeze through these special syndromes and then we can have some questions and answers. So Horner syndrome, we kind of touched on. It's a lack of sympathetic innervation to the eye. So the eye will be sunken. The third eyelid would come up. You can see some drooping of the face, and that pupil should be really small or myotic. There's a very long pathway that starts in the brain, goes all the way down the spinal cord, comes out of the spinal cord, goes all the way back up by the ear to come back to the eye. So there's a lot of areas that Horner's can come from, but it's helpful if you can see it to report it, and we on the phone can be a little more helpful as to picking out where it is. We talked about postures for brainstem lesions. So decerebrate rigidity is something that you can see. So the head and neck are generally apostotnic and held dorsally. All 4 limbs will be rigid with this posture. It's not to be confused with decerebellate rigidity. So again, the head can be apostotnic, held up. You'll see rigidity in these front legs, but you'll see flexion in the back legs. These patients will be very alert, very mentally appropriate, but can't work. This decerebellate rigidity is more indicative of a cerebellar problem. So they're alert, they're conscious, they know what's going on, but they can't get out of this posture because of damage done to the cerebellum. Shift Sherrington posture is something else that we can see that is difficult to try to discern between other things. So when you have a very severe T3, L3 lesion, so mid to lower back in the spine, sometimes you lose inhibition to the front legs, they'll go rigid. And so it can look like a brain problem for these dogs, but if you get them up and try to walk them, they will walk with the front legs, unlike the other postures, but those back legs will still be weak or plegic, depending on the patient. So you'll be able to see that those legs will work. It's only when they're laying on their side that they'll get into this rigidity. Finally, you can have a special syndrome called spinal shock that can be difficult to assess. So this happens when a dog has a T3, L3 lesion, so mid to lower back, very common for disc herniations. The lesion can be so severe that there's inflammation, the patient will lose reflexes in the back legs. So it can look like an L4-S3 instead of a T3, L3. It's kind of more of an academic thing. Ultimately, we image the dog's spinal cord either way, but can be helpful to assess and just know that the dog's had a severe lesion. Lastly, paradoxical vestibular disease can exist. So sometimes a patient will have a head tilt to the left, but paw placement deficits on the right. But just remember, the legs don't lie. If the right side of the body is affected, that's the side that the lesion is on. And again, very academic for us to want to pick this out on just an exam, but something that you can see that doesn't quite match up, but there's a reason for it. Okay, so last little guy, this is a paradoxical vestibular guy. He had, unfortunately, a brain tumor to his cerebellum. So notice the right side head tilt, but it's the left side of his body that's very over-exaggerated, very reaching. So remember, the legs don't lie. It was the left side of the cerebellum that had a problem with this dog. Okay, so I'm sorry that took a little bit of time, but I think we still have a few minutes for questions. So please feel free to let me know any questions you have. I'll open up that now, and happy to go through any of those. All right, so give me just a second. I'm gonna go through these real quick and see what has been flagged. Okay, so the first question we have here is where is the lesion in the paradoxical vestibular syndrome? So there's a couple of different places that this could occur, but generally it's part of the cerebellum, so that part of the brain that sits in the back. And generally there is a connection between the brainstem and the cerebellum that's called the caudal cerebellar peduncle, and that is the most common area where we'll see paradoxical vestibular disease. So it'll be on the side of the leg or the paw placement deficits, but it will cause a head tilt to the opposite side of the lesion because of a lack of inhibition and the way that the cerebellum sends inhibition signals. So that's a great question. It can also arise from some other areas of the cerebellum or also some of the first spinal nerves as they come out of the spinal cord. Those are more rare. Most commonly, it's in the cerebellum. So that's a great question. Next question we have here, how do you treat the dogs for PRN if you can't confirm a specific process? I guess I'm not exactly sure what the acronyms are here. Peripheral neuropathy. I think it's how do you treat dogs for peripheral neuropathies if you can't confirm a specific diagnosis. So generally, if that's answering your question, please let me know. If it's not peripheral nervous system, then reach out and I'll answer specifically. But we do have tests for, so you have a peripheral nervous system problem. You want to think of things like tick paralysis. So put flea tick medications on those patients, give them time, see if they get better, or find a tick and pull it off. Yeah, okay, so it came up, so for polyradicular neuropathy, so the coonhound type of paralysis. So generally, you're going to need electrodiagnostics to diagnose that and rule out the others. Generally, it's giving these patients lots of time to recover, so sometimes weeks they'll need to recover. So in that meantime, down dog care, flipping the patient, making sure that they stay clean, making sure they don't get things like pneumonia, if they have any vomiting or regurgitation from the peripheral neuropathies. So a lot of just supportive general care for the polyradicular neuropathy. Other peripheral diseases would be things like fulminant myasthenia gravis. You'll check your myasthenic titers for those patients. Here in Florida, you can get coral snake envenomation that can cause lower motor neuron signs, so you would get those things in your history. So for those polyradics, there's nothing we can do to make them faster. They do just need a bit of time, and basically to try to avoid the complications, pneumonia, regurging, those sorts of things. So it's a great question. Is it possible to have a spinal shock in a cervical lesion localization? So the answer to that is yes. I have had one patient that had, it was a larger breed dog that had a very severe disc herniation with lots of hemorrhage at C3-4. The dog had no spinal reflexes in its legs. It's very rare. I did write up that report. Hopefully it's getting published in JAVMA at some time soon, but it is possible. But if you see a patient that has reflexes absent in all four legs, I would more likely assume that that dog is a neuropathy, kind of like the polyradicular neuropathies that we talked about, before assuming it's a spinal shock, because that is pretty rare. But that's a great question. It does exist. Lean towards horses over zebras in that situation, but it is possible. And then can we explain a cross-extensor reflex? Yes, so cross-extensor reflexes will be something that we can see when we're testing withdrawals. So we'll use the back legs as an example. So if we have a dog laying on its side and we pinch on the left back leg, we should see the withdrawal of that leg. And sometimes you'll see the right leg go and extend at the same time. That's called a cross-extensor. And what's happening is you're losing a lack of inhibition upwards in the spinal cord. So if you have a T3-L3, you expect the dog to have the reflexes, but it's upper motor neuron and losing inhibition, and you'll see the cross-extensor from T3-L3s. So basically, just when one leg extends when you're doing the withdrawal, that's called a cross-extensor. It means there's a lesion higher to that spinal cord segment, if that makes sense. These are all really good questions. I think that brings me up to speed on all of the questions that are here. I believe we have another 4 minutes. So if anybody else has any other questions or things that they'd like answered, we have some time. I'm happy to go over them. So we'll give you guys a few more minutes here. All right, so while we're waiting to see if there's any other questions here, quick reminder, you can always email us or reach out to us if you have a case or have questions on that, or if you have questions specifically about the neuro exam, feel free to email us. Final reminder, just remember that you'll get your CE for this lecture emailed to you 1 hour after this ends. So just be patient and it will come to you. If you do not get it, an hour after this ends, please reach out to us. We'll be happy to help troubleshoot, but just know that it's not immediate. There's a couple people saying thank you on here. You're very welcome. It's a pleasure to be here. I hope that it's helpful. It's hard to cram the neuro exam in basically a year's worth of anatomy all into one thing. So you're very welcome. Please let us know if you have any questions. I have another question here. So what is the prognosis of a dog with disc herniation, and what would be the best treatment possible? So that's a great question. So for dogs with disc herniations, generally the prognosis can be good. So we kind of grade them with how severe are they. Are they able to walk and they just have pain, or are they able to walk, they have some pain and they have some incoordination, so some of those legs are a little bit loosey-goosey? Generally speaking, those guys have a great chance of making recovery with medical management alone. The trouble starts getting into when we start having dogs that lose the ability to walk on their own. So if they're still able to move those legs, but they can't walk, with medical management alone, so strict cage rest, pain meds, anti-inflammatories, those dogs can get into a 60 to 70% chance of making a full recovery. But with surgery, they can generally get to 95, percent, depending on what you're reading. So better and faster generally. Worst case scenario is when you have a dog that has become paralyzed and has lost the ability to feel his toes. So you got this dog, it is dragging, there is no movement, you take your hemostats, you pinch that toe, the dog gives you no reaction. That's the worst grade of neurological damage that you can see. So if it is from a disc herniation, dogs that are medically managed in that state have a less than 5% chance of making a full recovery. So that's overall pretty poor. With surgery, dogs that have lost the ability to feel their toes are at 50-50. So unfortunately, it's a little bit of a coin flip for those patients. Those are patients that we want to intervene and image and take to surgery sooner rather than later. So those are definitely things you want to refer as soon as possible, because their prognosis definitely changes. That is a great question. Let's see, I think there, one more question here. So why can we have lower motor neuron signs in forelimbs with a confirmed disc herniation at C3, C4? So if you're having lower motor neuron signs from a disc herniation that has happened in the neck, it is possible to have spinal shock, like we said, but it's a bit more rare. Depending on the age of that dog, sometimes you'll lose things like patellar reflexes, or if they have severe arthritis, like old cruciate ligament injuries, those reflexes are reduced from an orthopedic reason. So it's hard to know exactly on a case-by-case basis, but you could have spinal shock. They could have a concurrent nerve issue that maybe has gone unnoticed, or they could have some orthopedic components to make some of those reflexes a bit weak. So those would be the three things that we would look for. And another question that came through is when there's a loss of the nociception, so when there's a loss of pain perception to a limb, what can we do at this point? So it depends on the cause. So if it is a disc herniation, we talked about medical management overall has a poor outcome, less than 5% kind of make a recovery. Surgery would be more 50-50. So those are patients, if it's a disc, that you'd want to refer. If you've lost pain perception, so you can't feel your toes secondary to a traumatic accident or a cancerous process, some forms of trauma, things like that, their prognosis is really poor. So we would want to assess those patients, try to treat the cancer, try to stabilize a fracture if it's present, and generally try to get those dogs into rehab. But that prognosis is really poor, sometimes even with surgery. All right, a couple of other questions rolling in here. Do steroids still have any role in the medical management of disc disease? So that is a clinician-dependent question and a great one. So generally, I will try to get by with anti-inflammatories for patients with just back pain that are mild, along with maybe gabapentin for nerve pain, muscle relaxants if needed, etc. But sometimes I will reach for steroids for dogs that I worry about that could have complications or could get worse, or dogs that I've MRI'd, taken to surgery, and I've seen how inflamed the spinal cord is, I will generally reach for a steroid. So there's some research to show the steroid's going to get into the nervous system and bring down the inflammation better than an anti-inflammatory like carprofen, meloxicam, Duramax, etc. But there are studies that show that steroids do tend to have more of a higher morbidity, mortality type of problem. So GI ulceration, PUPD, prone to infection. So making sure that you're using that steroid appropriately and an appropriate dose is important to try to avoid some of those problems. Both anti-inflammatories and steroids have a purpose in management of disc herniations. I've used both. It's kind of clinician dependent and case dependent on which one I'll reach for. A lot of the times, you guys are seeing these cases first before they're referred to us, and I'll just work with whatever you've started and just make sure that the dog's not having problems and do a wean schedule if I need to of steroids. But that's a great question. Is a bit clinician dependent. Okay, guys, I think I have answered all the questions on here. If you have some questions, please feel free to email them at this point, and I'll be happy to reach out and answer those for you. But for now, we'll call it done, and we will hopefully continue to have some online CE for everyone while we're going through this pandemic. So we hope that all of you guys stay safe out there, and please let us know if you have any more questions. Thanks.